Ladies and gentlemen, we're going to start a little early since there are one or two of you here. And also I have to leave shortly before the hour because I've got to go to Doug Hoyle's memorial service across the way, so I shouldn't be late for that. But the team are going to be here for a little longer than that.
We certainly are, yes.
For an hour or so. Now, you all presumably know the background of the Lucy Letby issue, the miscarriage as I view it, and today what we're here to do is to present a report which is the idea, the genesis, the creation of Dr. Xu Li, who's sitting next to me, who will do most of the speaking today, who was originally involved in the case because one of his papers was misreported, really misused, and he then came and gave evidence in the leave to appeal or the appeal?
The appeal.
The appeal, in the appeal. Unfortunately, at that point, without effect. But this report, we will, just in practical terms, when Dr. Li concludes his remarks, we'll issue copies of this, physical copies here in the room, which is basically the summaries of the report. And we will also send PDFs to all of your emails if we have them, so that you will have the hard copy available to you to refer to. Now, we're very lucky. Dr. Li and his team have done all of this pro bono, all of this entirely out of the good of their heart, and he's come here today, I suspect at his own expense, to address this issue and put right what I think, anyway, is one of the major injustices of modern times. So he's a very well-known, very well-respected medical expert, particularly in this sphere, and the people he's brought together, as you will hear in a minute, are a spectacularly high-ranking bunch of world-class experts. The other people on the panel here, we'll come to them in a moment, is Mark MacDonald, who is Lucy's defence barrister, and Nina Modi, one of the team, but also pretty much our senior neonatologist in this country. She's a professor at Imperial, past president of the Royal College of Paediatric and Child Health, and is similarly engaged on the injustice that we're facing today. But with no more ado, may I introduce Dr. Xu Li, the star of today's show.
Thank you. Well, thank you, Sir David. My name is Xu Li, and I'm here to share with you the findings of the International Expert Panel on the Lucy Letby case. But before I start, I'd like to share the sympathies and condolences of members of the International Expert Panel with families of the affected infants. We understand their stress and their anguish, and our work is not meant to cause more distress. Rather, it is meant to give them comfort and assurance in knowing the truth about what really happened. We know that they want to know the truth, and that is why we are here, to tell the truth. Should they have any queries or concerns, we'd be pleased to discuss them with them. So the background to this conference today is that in August of 2023, Lucy Letby was convicted in the murder of 7 babies and attempted murder of another 7 babies at the Countess of Chester Hospital Neonatal Unit. In April 2024, she appealed her conviction, but it was rejected. I testified at her appeal and was concerned that there were problems with the medical evidence that was used in her trial and appeal. As Lucy had exhausted all avenues of appeal, I proposed to Lucy's solicitors at the time that I would convene an international expert panel to examine all the medical evidence in detail and to produce an impartial, evidence-based report about the causes of death or injury of all the cases involved in the trial. The report would be released regardless of whether the findings were favorable or unfavorable to Lucy. Lucy and her solicitors agreed. So the International Expert Panel is an independent panel of some of the most experienced and distinguished neonatologists and pediatric specialists in the world. Our objective was to provide an impartial, evidence-based report about the causes of death or injury among the patients in the Lucy Letby case, based on the medical evidence. There would be no determination about innocence or guilt of the defendant. I was instructed to convene an international expert panel to examine the medical evidence. The panel is independent and worked under the agreement with Lucy and her lawyers that all findings would be released even if they did not favor the defendant. The defendant and her lawyers provided the panel with access to medical records and witness statements used in the trial. The panel self-determined how to examine the medical evidence, how to interpret the findings, and to produce a report independently. As chair of the panel, I issued the following instructions to the members of the panel. First, to review the medical records and determine the cause of death, in their opinion, or injury. Second, to review and comment on the expert witness statements and opinions. And third, to provide an independent report about the causes of death or injury. The methods we used was that each case would be examined by 2 experts independently, who then submitted their reports to me, the chair. If their findings were in agreement, their conclusions were accepted as final. If their findings differed, a 3rd member of the panel was asked to review the case, and a consensus opinion was then developed. Summaries of each case were developed by the chair and approved by the panelists who examined the case, and then shared with the whole panel. Strict confidentiality was observed. I am the chair of the panel, and I invited members of the panel to participate on a voluntary basis and to work pro bono. Members of the panel, including myself, did not receive any benefits in cash or in kind, and even my trip here today is self-funded. The panel comprises 14 very experienced and well-known experts from highly prestigious institutions in 6 countries around the world, including Canada, the United States of America, Japan, Germany, Sweden, and the United Kingdom. They include 10 neonatologists, 1 pediatric surgeon, 1 pediatric infectious disease specialist, 1 senior neonatal intensive care nurse, and 1 other pediatric specialist. With the exception of myself and the member from the UK, the other members of the panel knew of the existence of the case, but otherwise had very little knowledge about it. I will give brief introductions to the members of the panel in a moment, and their biographies are in the summary report, so you can refer to it to see who they are and what they have done. We also relied on the reports of 2 external experts in engineering for information about insulin and C-peptide testing, and these experts were under instruction by those representing Lucy Letby. Now, the members of the International Expert Panel are as follows. I'm the chair. I'm Professor Emeritus at the University of Toronto, an honorary physician at Mount Sinai Hospital, and president of the Neonatal Foundation and founder of the Canadian Neonatal Network. I was previously the head of neonatology at the University of Toronto and the Hospital for Sick Children. Next is Professor Eric Eichenwald, who is Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania in the United States. He's also the chief of the Division of Neonatology at the Children's Hospital of Philadelphia and holder of the Thomas Friedrich McNair Scott Endowed Chair. Professor Helmut Hammler is the Senior Medical Director of the European Foundation for Care of Newborn Infants in Germany, and formerly he was the head of neonatology at the University of Ulm and Ulm Hospital. Professor Tetsuya Isayama is the head of the Division of Neonatology at the National Center for Child Health and Development in Tokyo, Japan, and the director of the Asian Neonatal Network. Professor Joanne Langley is professor in the Department of Pediatrics and Community Health and Epidemiology at the Faculty of Medicine in Dalhousie University in Canada. She's also the holder of the Canadian Institutes of Health Research GlaxoSmithKline Chair in Pediatric Vaccinology and head of the Division of Pediatric Infectious Diseases at the IWK Health Centre in Halifax, Canada. Professor Nina Modi is one of the most senior neonatologists here in the UK. She is the Professor of Neonatal Medicine and Vice Dean International at Imperial College London, Honorary Consultant to the Chelsea and Westminster NHS Foundation Trust, and President of the European Association of Perinatal Medicine, and a former President of the Royal College of Pediatrics and Child Health here in the UK. Sandra Moore, I don't have a picture, unfortunately, but she's the senior staff nurse at the South Lake Regional Health Centre in Newmarket, Canada, and a member of the Sullivan Medical Legal Experts, Richmond Hill, Ontario. Professor Michael Norman is professor and senior physician at the Department of Clinical Science, Intervention and Technology at the Karolinska Institute in Stockholm, Sweden. He's the chairman of the Swedish Neonatal Quality Register and founder of the International Society of Evidence-Based Neonatology, or EPNEO. He was also formerly the head of the Division of Neonatology at the Karolinska Institute Hospital. Professor Bruno Piedboff is Professor Titulaire et Pédiatrie at the Université Laval. He is coordinator the Services Cliniques de Rui de la Université Laval and director des Affaires Universitaires, Ministère de la Santé et des Services Sociaux au Québec in Canada. Now, I will provide today, this is Professor Prakash Kumar Shah, who is professor at the University of Toronto in Canada, and he is also the head of pediatrics at the Mount Sinai Hospital, and has a number of different other appointments, including senior clinician scientist at the Lunenfeld Tannenbaum Research Institute, director of the International Network for Evaluation of Outcomes of Neonates, INEO, director of the Preterm Birth Network, and scientific advisor and past director of the Canadian Neonatal Network. Professor Nalini Singhal is Professor Emeritus at the University of Calgary and a member of the WHO AAP Helping Babies Survive program. She was also the head of neonatology at the University of Calgary previously. Professor Eric Skarsgård is a professor in the Department of Pediatric Surgery at the University of British Columbia in Vancouver, Canada, and also the director of the Canadian Pediatric Surgery Network. Professor Ann Stark is the professor in residence at Harvard Medical School and also director of the faculty development in the Department of Neonatology at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And she was formerly the NICU director at the Boston Children's Hospital in Boston. And finally, we have Professor Jeff Chase, who is a distinguished professor of engineering at the University of Canterbury in New Zealand. Now, he's not a member of the panel, but he is one of the experts who provided us with information about insulin and C-peptide testing that we'll be using in this presentation. Okay. Now, today I will provide you with a summary of our findings. Copies are available at the side table, and you will be able to access them after this press presentation. The full report will be provided to Lucy Letby's barrister later this month. Now, the panel examined all 17 cases with which Lucy Letby was charged, and they are labeled patient 1 to patient 17. The cases involve a number of different allegations about causes of death or injury, which can be roughly grouped into 6 categories. First, air embolism caused by injection of air into the intravenous system. 2, splinting of diaphragm caused by injection of air into the nasogastric tube. 3, dislodged nasogastric endotracheal tube causing collapse. 4, hypoglycemia caused by injection of insulin. 5, trauma to the abdomen or gastrointestinal tract. And 6, overfeeding. Now, in the interest of time, I will only discuss 1 or 2 representative cases from each of the 6 groups, because otherwise we'll be here all day. All reports, however, will be provided to Lucy Letby's solicitors. So I will start with each of these cases that I'm presenting today. It'll be very brief, because these cases are quite long for many of them. And if we had to go through all the details, we'd be here forever. I can tell you that it took days and days and sometimes weeks to go through each case in detail. So we're going to give you the highlights of what happened. talk about what the allegations were in the conviction and what did the panel find. So baby 1 was a case of air embolism. This was a preterm baby, twin 2 infant, who was born by emergency cesarean section. And he was well until the second day of life, when he suddenly collapsed and had skin discoloration with blotchy patches of brighter pink on a bluey gray background. And he did not respond to resuscitation. The allegation was that baby 1 died from injection of air into the intravenous line, causing air embolism and resulting in collapse, patchy discoloration of the skin, and eventually death. So, to begin, I will give you a little bit of background on the publications of air embolism. The prosecution, in part, based their allegation on a paper that I had written in 1989, where I described all 57 cases that had been published to that point in time. And it showed that the babies would present with a certain number of symptoms or signs, and also that about 10% of them had skin discolorations of different kinds. At that time, I did not distinguish between arterial and venous air embolism. And in this particular case, the allegation is that she injected air into the venous system, into the veins. So there's a difference between arterial and venous, because the arteries carry blood to the body to supply the organs and the skin, whereas the veins actually carry blood away from the organs or the skin to the heart and to the lungs. And in the new paper that I had published in December of 2024 in the American Journal of Perinatology, a copy of which will be in the summary report that you will receive, we actually separated the cases with arterial venous air embolism from the cases with venous air embolism. And what we found was that in the cases where air was injected into the veins, there were no cases of patchy skin discolorations ever described in the literature. So the notion that these babies can be diagnosed with air embolism because they collapsed and had these skin discolorations has no evidence in fact. All right? None of this actually has ever been described. If this is true, it will be the first case ever described, but it's never been. And there's a reason for that. The reason is that in the arterial system, when you inject air into the arterial system, it goes directly to the skin or the blood vessels, or to the organs. Whereas in the venous system, it has to go to the lungs first. And the lungs has a complex bed of very small blood vessels that filters out all the air bubbles if they come through, so that they don't actually get to the arterial system. Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system. But it has to go against pressure, because the pressure in the arterial system is higher than in the venous. And so what we found in the literature was that there were no cases that have been described where, in fact, these skin rashes have occurred. So let's do away with that theory, all right? The notion that these cases are air embolism because they collapsed and because there were skin rashes has no basis in evidence, okay? Let's be very clear about that. Now, so what can be the possible causes then? Why did this baby suddenly collapse? So we went into the history of this baby to see what actually happened. So in this baby, the mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies to attack tissues in the own body. Now, these antibodies can trigger blood clots to form in arteries and veins. And during pregnancy, these antibodies can pass through the placenta to the neonate and lead to thromboembolism, which means clotting in the baby. Particularly happens if there is concurrent infection. Now, post-mortem of baby 1 showed that there was a recent non-occluding thrombus in the liver, which means that, in fact, there was a thrombotic event that happened in this baby after the baby was born. On the day of the collapse, the baby's IV tissued at 1600 hours. Tissued meaning that the IV that was supposed to be in the vein somehow penetrated the vein and came out into the tissues. And so the infusion was not going into the circulation, was going into the tissues, and so the area was getting swollen because the infusion was coming out. And so because of this, they removed the IV and replaced it with an umbilical venous catheter. But the first insertion was malpositioned, and so they had to replace it again. Later on, a long peripheral line was then inserted at about 1900 hours. Now, they then took an X-ray, etc., to make sure it was in the right position, and eventually the infusion was restarted. But an infusion was restarted at 2000 hours. So there was a period of up to 4 hours when these lines were in, but there was no infusion. Now, here's the problem. Even in a baby without any problems, we avoid putting lines in without infusion, because if you do that, clots can form on these lines. In this case, the baby actually predisposes to clot formation because of the antiphospholipid syndrome. And therefore, to have lines in there for 4 hours without infusion is a risk. All right? Now, what then happened was that minutes after the infusion was restarted at 2000 hours, baby 1 collapsed. It is most likely that there was a thrombus that formed on the tip of the catheter that then dislodged when the infusion was started, and it migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. It is also possible that baby 1 had placental fetal vascular malperfusion. So what's that? That's a condition in which the fetal villi in the placenta present small thrombi that can travel to and occlude small blood vessels in major organs like the heart, brain, and liver. And if a small thrombi lands in an artery supplying a critical structure like the brainstem, it can also cause sudden death, and they are very hard to find on post-mortem, because these vessels supplying these critical areas of the brain or the heart are very tiny. And so all you need is a small thrombus to occlude it. When you're doing a post-mortem, you're doing cuts to see whether you see anything. And you have to actually cut exactly where that thrombus is in order to identify it. So just because a post-mortem doesn't identify it doesn't mean it isn't there. Right? And in the second condition, which is fetal vascular malperfusion, these collapses can occur 1 to 2 days after birth. So one of these 2 causes probably caused it, and we think it's the first one because of the temporal relationship with the lines that were inserted, the predisposition to formation of clots on these lines if you don't infuse it, and then the occurrence of the collapse just minutes after the line was re-infused. So our conclusion is that baby 1 died from thrombosis, and that there was no evidence of air embolism. Because in this baby, the allegation for air embolism was that, number 1, the baby died, we could not find a reason for it. Number 2, this baby had this collapse accompanied by these skin discolorations, which was consistent with what the allegation was with air embolism. And what we are saying is, first of all, the second reason doesn't hold, because air embolism by the venous system does not produce these kinds of skin discolorations. Number 2, there is a plausible and reasonable reason why this happened, which is what I just explained. So for both those reasons, we feel that this diagnosis is wrong, that this is not pulmonary air embolism. In fact, this is because of thrombosis. Now the next baby, oh, I forgot to show you that, but hopefully you understood what I was saying. Next baby is baby 4, which is another case of air embolism. Now, baby 4 was a term baby who was born by emergency C-section after prolonged premature rupture of membranes. She became pale and floppy at 12 minutes of life and required resuscitation. She continued to have respiratory distress afterwards. She was then admitted to the neonatal unit, and continuous positive airway pressure support for the respiratory distress was started, and antibiotics were started, but only 4 hours later after the baby had admitted to the NICU. The chest X-ray showed pneumonia. On the 3rd day, the baby became mottled, had dark brown and black tracking lesions across the trunk, and 2 evolving purpuric-looking patches on the abdomen. She had repeated episodes of apnea and desaturation until final collapse and death. Now, the allegation is that baby 4 was a stable baby after the baby was born and admitted to the NICU. And then on day 3 of life, the baby suddenly collapsed, and that this was due to injection of air through the intravenous system, causing air embolism, resulting in patchy discoloration of the skin and death. Now, first of all, I would like to just repeat what I said earlier, that there is no evidence that air embolism through the veins results in patchy discoloration of the skin. So let's just dismiss that, all right? That's not a consideration. So what could this be? Well, first of all, this baby was born after prolonged premature rupture of membranes. What it means is that all the babies in utero have a membrane around them that protects them. And if the membrane is ruptured, infection can ascend. Also, membranes often rupture because of infection. So for that reason, there is a standard treatment guideline in this country and in other countries that if there is prolonged premature rupture of membranes, the mother should be given antibiotics right away so that the baby can be protected from any infection. In this case, that was not done. The mother did not receive antibiotics. Second, there were important delays in the admission, diagnosis, and treatment of the baby after the baby was born. The baby was admitted to the neonatal unit only 3.5 hours after birth, at which point she was noted to be cold, blue, dusky, and in respiratory distress. She had polycythemia, which means that she was looking very dark in color, and she had infection because the blood test at the time showed white cell count that was very high and a neutrophil cell count that was very high, which are all indicators of infection. So there was a long delay in admission and treatment. Now don't forget, the antibiotics should have been given a long time ago during the labor itself. So this was a very long delay. You were talking about half to a full day or more, where the baby was not receiving antibiotics when in fact there was already infection. On top of that, the blood gas that should have been taken to see how the baby was doing was not taken until after 4 hours after birth. And then when it was taken, it showed very high carbon dioxide and respiratory acidosis, meaning that the baby was in respiratory failure all this time, and nothing had been done for 4 hours. The continuous positive airway pressure support for the baby was again started nearly 4 hours later after birth, despite the baby having respiratory distress. Now, she was eventually electively intubated, but 3 attempts were required before she was actually intubated and ventilated. And these delays subjected the baby to unnecessary acidosis, high CO2, and delay of antibiotic treatment. This was not a stable baby, as alleged by the prosecution witness. And in fact, this baby continued to deteriorate for the next few days until final collapse, with worsening symptoms of infection as we went along. Let's see what happened. So she was admitted, and as I said to you earlier on, she was already sick on that day. On the following day, she developed fever. She had intolerance when the CPAP was removed. In other words, she could not tolerate coming off the CPAP support. She had continuing deterioration of blood gases over the next day. She had increasing metabolic acidosis. All these indicates that the infection was in fact getting worse. The baby was not stable. And then on the next day, on day 3, she further deteriorated with rising CRP. Now, CRP is the test we do to see whether there's infection. And if the CRP is going up, it means the infection is getting worse. If the CRP is going down, it means it's getting better. And this was going up. There were repeated episodes of apnea and desaturation, again indicating the baby was clinically getting worse, not better. She then developed prolonged coagulation times. Coagulation times means how long does it take for your blood to clot? And normally, for all of us, it should clot within a certain period of time. If it takes longer than that, it means that there's a coagulation defect. Something is wrong with your blood. And in this case, the coagulation time was increased. Now, this is a serious development because it indicates that the infection is going out of control. Most of us, when we are infected, we are sick, whatever, the coagulation times don't change. But if the coagulation times change, it means that this baby is going into what is called disseminated intravascular coagulation. And this is a condition that appears when the baby is severely infected and severely ill because it causes spontaneous coagulation of the blood throughout the whole circulatory system. The blood just starts to clot everywhere. And as it clots, it consumes the coagulation factors, and that's why you see a coagulation defect. And then that leads to spontaneous bleeding in all the organs and elsewhere in the body. So when you see something that's starting to cause coagulation defects, this is in fact an early sign of DIC that is developing. And so the blood vessels in the skin are compromised because if you have clotting in the blood vessels of the skin, they compromise the blood flow, which together with hypoxia, triggered dilation, and contraction of small vessels in the skin, which then results in the skin discoloration that you see, and tracking lesions and so on. And she ultimately collapsed and deceased. So this baby died of systemic sepsis, pneumonia, and disseminated intravascular coagulation. The mother should have received intrapartum antibiotics prior to delivery. There was delay in recognizing respiratory distress after birth. There was delay in starting antibiotics and delay in starting treatment for the respiratory distress. We did not find any evidence of air embolism. All right. Now, the next baby is baby 9, where the allegation is that the baby received nasogastric tube air and then subsequently was also given air through the IV into the intravenous system, which caused air embolism. Now, baby 9 was a preterm infant with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease, who had repeated episodes of apnea, desaturation, and bradycardia, needing resuscitation during the hospital stay. And the baby was in hospital for quite a period of time. The baby also had an episode of lung collapse and reports that there were thick gelatinous airway and oral secretions. And one of the registrars, who is a mid-level doctor in the NICU, stated that it is not unusual for babies on breathing support to get secretions, but it was a bit unusual for them to be so stubborn at being removed like in this baby. And after each period of apnea and desaturation, they had to resuscitate the baby using back and mask ventilation, and then the abdomen was distended. And abdominal x-rays taken after that showed gaseous distension of the intestines. At 2.5 months, she had an episode of severe apnea, bradycardia, desaturation, and heart block, and then deceased. So it was alleged that air was injected into baby 9's stomach through a nasogastric tube, leading to recurrent episodes of abdominal distension, which then splintered the diaphragm and caused respiratory arrest and failure, needing resuscitation. It was also alleged that on the 13th of October, that the apnea alarm was deliberately turned off, resulting in delay and response to a collapse. And that on the 15th of October, air was injected into her intravenous tubing, causing air embolism and death. So we looked at this case in detail, and what we found was that baby 9 was a very preterm baby with intrauterine growth restriction, respiratory distress syndrome, and chronic lung disease. Also, that in fact, surveillance cultures, which are normally done after a baby is admitted to the unit from outside, to make sure that there are no dangerous bacteria being brought into the NICU. So they routinely culture all these babies after admission. And in this case, the surveillance culture revealed a bacteria called Stenotrophomonas maltophilia, which is a gram-negative bacteria from her endotracheal tube. And the doctors in the unit were duly notified that that was the case. Now, this particular bacteria is unique because it is a multi-resistant opportunistic pathogen that can colonize the airway in biofilms that are resistant to antibiotics and impossible to clear in patients with chronic lung disease. The thick secretions can block the endotracheal tubes, which led to the endotracheal tubes constantly being blocked and replaced, and interfere with ventilation in the small airways of these vulnerable infants, which together with other factors like chronic lung disease can lead to recurrent episodes of apnea, desaturation, bradycardia, respiratory failure, and collapse. And decolonization with Stenotrophomonas maltophilia would have further compromised her ventilatory capacity. Now, her initial abdominal distension was likely due to sepsis causing ileus, or to lactose intolerance because there's a family history and the stools were positive for reducing substances. But the subsequent repeated abdominal x-rays showing intestinal gaseous distension were all taken after resuscitation and bag and mask ventilation, so that the air was likely introduced by the resuscitation, not because the air was there previously. Right? Also, a nurse explained that the reason that the apnea alarm did not sound was because the apnea alarm is set to go off if there is a 20-second period where there are no breaths. But because this baby was gasping at less than 20 seconds each time, the apnea alarm wasn't triggered. So it wasn't because it was switched off. It was because the baby was gasping, and so it wasn't triggering the alarm. Right? Now, this baby was not treated for Stenotrophomonas maltophilia, and there is no evidence that air embolism was at all involved. We concluded, therefore, that baby 9 died of respiratory complications caused by respiratory distress syndrome and chronic lung disease that were complicated by the Stenotrophomonas maltophilia colonization. The doctors failed to respond to routine surveillance warnings that this baby was colonized with this bacteria. They did not recognize the diagnosis. They did not treat her with the appropriate antibiotics which would have cleared this bacteria. This was likely a preventable death. There is no evidence of air causing splinting of the diaphragm or of air causing air embolism. There was no evidence that the alarm was turned off. In fact, the evidence is that the alarm was not turned off. Give me 1 second, I'm missing a page here. There we go, thank you. Now, baby 11 was a preterm baby who was resuscitated at birth and had a number 2 sized endotracheal tube that was inserted after 3 traumatic attempts. The baby was then ventilated. A 94% air leak was detected, and ventilation was continued. At 1.5 hours of age, she desaturated. The consultant entered the room, bagged the baby, but found that the chest could not move. In addition, he applied a capnography test, which was negative. He then removed the tube, re-intubated the baby, and the baby then recovered and was subsequently transferred to Elder Hay Hospital. So let's just understand what actually happened here. So when a baby has collapsed and the tube is in place, the consultant first has to check to make sure the tube is there. Because if the tube is in the right place, he would then ventilate the baby using bag and mask and so on. And in this case, he said that he attempted to ventilate the baby. In other words, he disconnected the endotracheal tube from the machine. He put on a bag and mask, and he bagged it to see whether the chest would move. And he said the chest did not move. And if the chest did not move, then potentially the tube was not in the right place. Secondly, he applied a capnography test. So this is a device that you connect to the endotracheal tube, and it measures carbon dioxide. So if the tube is in the endotracheal tube is in the trachea, then when the baby expires, carbon dioxide will come out, and this device would measure it. So if you measure carbon dioxide, you can say that the tube was in the right place. If you don't measure carbon dioxide, it is potentially not in the right place and potentially could have been removed. All right. The consultant, therefore, concluded and alleged that baby 11's first episode of clinical deterioration, which I'm talking about, was caused by deliberate dislodgement of her endotracheal tube because bagging failed to move the chest and carbon dioxide was not detected on capnography. He also alleged that the incubator alarms were deliberately turned off to prevent prompt rescue response because he did not hear the alarms when he entered the room. So we examined the evidence to see what actually happened. First of all, when the baby was born and required resuscitation, they took 3 times to intubate the baby because they had difficulty intubating the baby, and it was traumatic. And finally, they put in a size 2 tube. Now, this resulted in a 94% air leak. What that means is that when you pump air in, whether it's by a bag or machine, 94% of the air is actually leaking out. So only 6% actually gets into the lung. All right? That's kind of like using a straw and blowing through a garden hose and hoping that you can inflate something at the end of the garden hose, right? It doesn't work. So as a result, ventilation was ineffective because 94% of the air was leaking out and only 6% was entering the lung. Effective gas exchange could not occur, and mechanical ventilation could not generate sufficient pressure to keep the small air spaces in the lung open. So this led to gradual collapse of the small air spaces in the lung and deteriorating gas exchange. When the tipping point was reached, the baby decompensated, desaturated, and collapsed. Now, when the small air spaces in the lungs are collapsed, if you try to reopen these collapsed air spaces, it actually requires relatively high pressures because they are collapsed, and therefore you need higher pressure to actually open them. With a 94% air leak, bagging will not do the job because the air is all leaking out. It doesn't get into where it's supposed to go. In addition, the consultant was using a device called the Neopuff. Now, the Neopuff is actually a safety device because it's a valve that is pressure limited. So when you bag, it limits the amount of pressure you can give so that you don't give excessive pressure to the lungs. Now, in this case, however, because the lungs are collapsed, you actually need higher pressure to open it up. And so when you're using a Neopuff, you're not delivering sufficient pressure. So both these reasons will account for why the chest did not move when the consultant tried to bag the baby. The capnograph, as I explained, measures CO2. But with a 94% air leak, the CO2 is all leaking out. And the capnograph requires the CO2 to build up in the tube to the point where it can be detected. If the air is all leaking out, the CO2 is all leaking out and you cannot detect anything. And there's good studies to show that when the air leak is more than 20%, your ability to measure CO2 starts to drop. By the time you're 80% air leak, you measure nothing. And we've got a 94% air leak here. So for those two reasons, there's actually no proof that the tube was even dislodged. It was probably in the right place. It's just that the consultant didn't know what he was doing. The consultant also stated that he did not hear the alarms. But another nurse, in her testimony, stated in her statement that when I returned to the unit, I immediately became aware of the alarms sounding from baby 11's incubator, and I rushed in to help. So there is actually a statement from another nurse saying that the alarms were not off. They were actually working. Perhaps the consultant just didn't hear them. So our conclusions was that first, there is no evidence to support a dislodged endotracheal tube. The clinical deterioration was caused by the use of an undersized endotracheal tube, and the initial intubation was traumatic and poorly supervised. The consultant did not understand the basics of resuscitation, of air leak, of mechanical ventilation, and how the equipment that he was using, that were commonly used in the neonatal unit, like the Neopuff and capnograph, actually worked. There is evidence that the incubator alarms were not turned off. Right. Next, we're going to talk about baby 6. That's what we call an alarm.
That alarm was good.
Yes. Wasn't turned off. Now, baby 6 was a preterm twin 2, borderline intrauterine growth restricted baby, male, who was born by emergency cesarean section. He had mild respiratory distress syndrome and hyperglycemia requiring insulin treatment. And on the 5th of August, at about 1:30 in the morning, he then developed sepsis and hypoglycemia and was treated with antibiotics and intravenous glucose infusion. Over the next 17 hours, his glucose remained low, ranging from 0.8 to 2.4. And this was despite repeated doses of 10% dextrose to try and raise the blood sugar. In fact, they were given very frequently. Every time they tested it was low, they would give another bolus injection of 10% glucose. And that's like less than 2 hours between each dose. So it was very frequent that they were giving this. And still the sugar didn't come up. At about 1000 hours, which is about 9 hours after the initial hypoglycemia, it was noticed that his IV line was in fact tissued. And as I explained earlier, tissued means that the line was out of the vein, and therefore it was infusing fluid into the tissues. And it was also noted there was extensive swelling and induration, meaning very hard, of the right groin, thigh, and leg. What that means is that this infiltration had gone on for quite a long time, because otherwise you wouldn't have this amount of extensive swelling and induration of the groin, thigh, and leg. In other words, the IV that was giving sugar wasn't actually giving any sugar because it was actually going into the tissues. So the baby wasn't receiving any sugar, and that was why the sugar stayed low. Now, when this was noticed, the IV was turned off appropriately. So it was stopped at about 1000 hours. And then a long line was put in. And at 1200 hours, the IV was restarted. And at 1200 hours, it is also routine in this unit that all the IV bags are changed. So that for this baby, one would presume that the IV bag was not also changed. And then the sugar still remained low. So that at 1900 hours, the dextrose infusion was increased to 15% from 10%, and the hypoglycemia then resolved. Now, it was alleged that baby 6 was given exogenous insulin through the infusion bag because there was a prolonged period of hypoglycemia. Further, that when the infusion was stopped from 1000 to 1200 hours because of the IV being infiltrated, the sugar actually went up from 1.3 to 2.4. So how can that be? If you're not giving sugar, the sugar should be dropping. And so the conclusion that was drawn by the expert witness for the prosecution was that the IV bag must have contained insulin, and that's why it kept the sugars low. And when you stop the insulin because the IV was stopped, then the sugars came up. Thirdly, that the blood glucose after the infusion bag was changed at 1900 hours caused the sugars then recover, so that insulin must have been put into the bag before the bag was changed at 1900 hours. And finally, that they had done a test which showed that the baby had high insulin but low C-peptide, which indicates that exogenous insulin was used. So what does that mean? What happens is that when your body produces insulin, there's a small protein called a C-peptide that is cleaved off. So whenever you produce 1 unit of insulin, 1 C-peptide protein is also cleaved off. So you would expect that if you produce insulin yourself and it was not given externally, that both of these would rise. If, however, you're given insulin from outside, then the insulin would go up, but the C-peptide would not go up because there was no production by the body and no C-peptide would be produced, right? And in this baby, when they measured, they found that the insulin level was very high and the C protein was low. So it must mean that the insulin was being given by the outside, somewhere outside, and not being produced by the baby itself. So let's look at the evidence here. First of all, the hypoglycemia started with sepsis, which often precipitates hypoglycemia, all right, in these babies. And it was prolonged because the IV infiltrated for several hours. We don't know how long. We just know that at 1000 hours, the nurse found that this baby had a swollen groin and thigh and leg. So for some number of hours before that, the baby wasn't getting any dextrose. And that probably explains why the baby was hypoglycemic during this time. The second thing is that when hypoglycemia persisted, despite 10% dextrose, a higher dose of glucose should have been used. Because if you're giving 10% dextrose infusion and there's still hypoglycemia, it means it's not enough. You should be increasing the amount of glucose you're using. And that wasn't done until 1900 hours. So for the whole day, the same amount of glucose was being used. Instead, what they did was to give repeated doses of 10% glucose. Now, the problem is that that's actually the wrong treatment. Because the way to treat hypoglycemia is that you give a continuous infusion and then you titrate it to increase the amount required so that the glucose will then come up in the blood and come to the level that you require. When you give repeated bolus doses, which means that you just pump a big dose in at one time of 10% dextrose, it actually worsens the hypoglycemia. Because every time you pump a surge of glucose in, the glucose rises in the blood. There's a surge of glucose. And that triggers a surge of insulin production by the pancreas, because that's what it's programmed to do. And that surge of insulin will then force down the glucose, and then you get hypoglycemic again. So you end up with a yo-yo pattern where you see hypoglycemia, you pump in your sugar, it causes a surge of insulin, the blood sugar then drops, you test it again, now it's low again. Then you pump in more glucose, and it just makes it worse and worse. It's a vicious cycle that you keep doing. This is a very basic thing. We teach all our medical students not to do this. All right? This is what was done here. Now, then when the IV tissued, there was lack of glucose infusion for many hours because of the swelling, as I talked about, and that was probably one of the reasons why this hypoglycemia was so prolonged. Now, the next thing is that when the infusion was stopped from 1000 to 1200 hours, it was alleged that the blood sugar rose from 1.3 to 2.4. So how can that be if there's no sugar being given? What was not said was that in fact the blood sugar was 1.4 at 11:46 hours. In other words, for that whole period of 2 hours where the glucose was not infusing, the blood sugar was actually not rising. The figure of 2.4 was measured after 1200 hours when the IV had been restarted. So there is no evidence that in fact this baby's sugar was rising because of the IV being stopped. Right? Also at 1200 hours, the IV bag was changed. Now the infusion bags in this hospital were prepared in the pharmacy. They were then brought to the unit and stored in a cupboard. And were changed every day at 1200 hours. So this baby would have had at least 2 bags of IV fluid during that period of time. And in order for this baby to have had insulin introduced into the bag, it would have to have been done multiple times into multiple bags. Because if the bag was changed at 1200, then you would have to give insulin into that bag as well in order for that to happen. All right? Now, the blood sugar rose after 1900 hours. It was alleged that this was because the IV bag was changed in 1900 hours, and it was changed. But it was not because the bag was changed. It was because at 1900 hours, the dextrose was increased to 15%. So the baby got better, because now you are giving the appropriate amount of sugar to this baby. Right. So what about this problem with the insulin and C-peptide? Because as I explained earlier, the blood test showed high insulin and low C-peptide. And we know that this is something that has been well tested in adults and in older children. The problem is that this has never been tested in preterm infants. And preterm infants are not just little people. Preterm infants are different. They have different physiology and biology compared to adults and older children. They behave differently. And just because we see something that applies and is valid in adults and older children doesn't mean it's valid for preterm infants. So Professor Jeff Chase, whom you saw a picture of earlier on, is someone who has been studying this his whole life. This is what he does for a living. You know, his whole career he has been studying this. And what he reported, and a copy of his report is in the summary report that you receive later on, he reported that preterm infants have different insulin and C-peptide standards than adults. Exogenous insulin is unlikely to be the cause of hypoglycemia for several reasons. First, the C-peptide in this case would have been low for an adult or older children, but it was not low for preterm infants. In fact, the level for this baby would have been at 20 to 45 percentile of all preterm infants. In other words, right in the middle.
Average.
Or average for a preterm infant. It was perfectly normal. Right. Second, if the insulin was really that high, the potassium levels would have been reduced. But in this baby, the potassium levels were normal. So that couldn't have been the case. The glucose level should be lower if exogenous insulin was used. And the insulin C-peptide ratio was within the normal expected range for preterm infants. All right? Because the experts in the trial were using standards for adults and for older children. They do not apply to preterm infants. All right? And finally, that preterm babies have a lot of antibodies. And these antibodies bind insulin. And when you measure insulin, it measures not just the active insulin in the blood, it also measures the insulin that is bound to these antibodies. And so you get a falsely high level of insulin when you measure the insulin in these preterm infants. Right. Finally, that the immunoassay that is used is unreliable because there are many interference factors. For example, if you have sepsis, if you have antibiotics, if antibodies, it will all cause these measurements to be wrong. And therefore, you get false positive insulin readings. And this baby had all of the above. Baby had sepsis, had antibiotics, baby had autoantibodies, etc. And therefore, we concluded that baby 6 had prolonged hypoglycemia because of sepsis, prematurity, borderline intrauterine growth restriction, lack of intravenous glucose when the long line infiltrated for a prolonged period of several hours, and also poor medical management of the hypoglycemia. In addition, baby 6's insulin level and IC ratios do not prove that exogenous insulin was used and are in fact within the normal range for preterm infants. Preterm infants, and especially those with illnesses and drug treatments like antibiotics, have different normative standards compared to healthy adults and older children. Right. Next is baby 15. Baby 15 was a preterm second triplet born by in-labor cesarean section, and the triplets were extracted very quickly, one after the other, a minute apart. And at 36 hours, he had rising heart rate and respiratory rate, temperature instability, and mild abdominal distension. On day 3, there was further deterioration. The abdomen became more distended. Visible loops of bowel were seen. The baby was uncomfortable after feeds, vomited, had a high blood lactate, carbon dioxide, bilirubin, and acidosis. He was intubated and given high-pressure ventilation. He then collapsed and had purpuric discoloration of the right chest. Resuscitation included intubation, ventilation, cardiac massage, and needling of the abdomen, which failed. So the baby died. Post-mortem showed a ruptured subcapsular hematoma of the liver. Now, it was initially alleged that baby 15 received inflicted blunt trauma to the abdomen, causing purpuric discoloration of the chest and a ruptured subcapsular hematoma of the liver, and that the abdomen was distended because air was injected through the nasogastric tube to cause gaseous distension of the intestines. And later, the accusation was then changed to say that, in fact, there was deliberate injection of air into his intravenous system to cause air embolism, collapse, and death. So let's see what really happened. Baby 15 collapsed because the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity that was sufficient to cause the hemoglobin to drop by half. In other words, half your blood was lost into the abdomen because of the rupture. Now, you should know that for all of us, if you lose 20% of blood volume, you go into shock. When you lose half the blood, pretty much you exsanguinate to death, right? So this is a very major event. Now, the subcapsular liver hematoma is the result of traction or shear forces that are applied to the thin, fragile liver capsule through the hepatic ligaments. In baby 15, it was highly likely that this was the result of extremely rapid delivery, and this is a well-recognized cause of birth injury. And one of the other triplets also had the same subcapsular hematoma, although it was not this severe. So the fact that two of them had the same problem, again, confirms that this was likely caused by birth injury. All right? In other words, when the baby is suddenly precipitously delivered and the traction forces are applied, that's when you get this injury. When you apply blunt trauma to the chest, you cannot generate the kind of shear or traction forces required to cause subcapsular hematoma. It doesn't happen, right? You can hammer the chest all you want. It's not going to cause this kind of a subcapsular hematoma. Now, bleeding into a subcapsular hematoma is characteristically initially very slow because there's a capsule around the liver, and so it is contained by the pressure of the enveloping liver capsule. And in the early stages, the clinical signs are insidious and difficult to recognize. Now, in this baby, as the baby got worse, they then intubated the baby and ventilated the baby with high pressures. That's again a mistake, because when you use high pressure ventilation, it decreases the venous return to the heart, and that causes congestion of the liver, which actually makes it worse. Now, the slow deterioration is characteristically followed by an acute collapse when the liver ruptures, when the capsule ruptures, and this releases blood into the peritoneal cavity. Now, the significance of the rising heart rate and falling pH before terminal collapse were not recognized, because what was happening was that there was insidious bleeding going on into the liver capsule and into the liver, and that was causing the heart rate to go up and the acidosis and so on, and this was not recognized. And then a needle was blindly inserted into the abdomen to try and relieve the abdominal distension. Well, this is something you don't do, and you don't do blindly. And unfortunately, this may have penetrated the right lobe of the liver, causing further injury. And this was noted by the pathologist as parenchymal hematoma and laceration. Blind direct trauma to the abdomen or the chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in the liver protected by the lower chest wall. The gaseous distension of the intestinal tract was likely due to swallowing of air and insufflation during non-invasive respiratory support, and not due to injection of air through the nasogastric tube. The suggestion that there was air injected into the intravenous line is nothing but conjecture. Baby 15 died from a subcapsular liver hematoma caused by traumatic delivery, resulting in hemorrhage into the peritoneal cavity and profound shock. This was not recognized antepartum. Now, the last baby I'm going to talk about is baby 7.
I'll find it for you. Copy.
Sorry, a couple of my pages are missing here. I need his alarm to go off again. Now, baby 7 was a very preterm baby with premature rupture of membranes, severe hyaline membrane disease, bilateral pulmonary interstitial emphysema, hyperglycemia, anemia, thrombocytopenia, patent ductus arteriosus. And so this baby had a lot of chronic problems, all right? And at 14 weeks of age, the baby suddenly developed projectile vomiting, large watery stools and desaturation, followed by apnea 2 hours later. The abdomen was purple and distended, and the baby was then transferred to Arrow Park Hospital, where baby was treated for sepsis, rising CRP, and then eventually recovered. And the allegations were that this baby was deliberately overfed, and this caused the baby to vomit. And further, that air was injected into her stomach through the nasogastric tube, causing the vomiting and clinical deterioration because the air in the stomach splintered the diaphragm and caused respiratory failure. So let's see what really happened. The first thing we can see is that the baby, in fact, had infection on the night of the vomiting because she clinically deteriorated with desaturation and apnea. And her CRP continued to rise over the subsequent days after she was transferred to Arrow Park Hospital. That showed that this baby was infected. And so the vomiting and the apnea that we saw at this hospital was the start of symptoms arising from that infection. All right? It had nothing to do with anything else. Second, it is not uncommon for the CRP to climb after onset of clinical symptoms when there's infection. So you cannot separate the two events and say, oh, the infection is just separate from what happened here. This was the start of the infection. She had vomiting and large watery stools, which are actually very common in enterovirus infection, which is quite common in these babies. It would explain why all the blood, urine, cerebrospinal fluid, and respiratory cultures were all negative for bacteria, because this was probably a viral infection by enterovirus, not by bacteria. But the CRP was high, indicating there was an infection, right? So this was a viral infection. In addition, large watery stools are not consistent with overfeeding. If you overfeed, you can get vomiting. You do not get large watery stools. On the other hand, enterovirus infection is associated with large watery stools. Now, the abdominal distension and discoloration of the abdomen are common when babies are ill with ileus, and they usually disappear when the baby recovers. The abdominal x-rays showing gaseous distension of the intestines were all taken after bag and mask ventilation of the baby and are consistent with air being introduced by bagging and ileus, which means that the intestines are not moving in a sick baby. The blood-stained fluid coming up the trachea are most likely the result of a trauma during intubation. Chest x-ray post-intubation did not show any consolidation suggestive of pneumonia or pulmonary hemorrhage. at the Elder Hay Hospital. She received 7 days of antibiotics and she recovered after 7 days, which is consistent with enterovirus infection because this is a self-limiting disease and it recovers after a few days and they get better. So baby 7, in our opinion, had vomiting and clinical deterioration because of infection, possibly enterovirus infection, which can cause all these signs and symptoms. There is no evidence to support air injection into the stomach or overfeeding. So just to summarize all the findings we had in terms of the medical problems that we are seeing at this hospital, we found that the medical histories were incomplete. There was a failure to consider the obstetric history. There was disregard for surveillance warnings about bacterial colonization. There was misdiagnosis of diseases in these babies. They were caring for babies that were probably beyond their expected ability or designated level of care. There were unsafe delays in diagnosis and treatment of acutely ill patients. There were poor skills at resuscitation and intubation. There was poor supervision of junior doctors in procedures like intubation. There were poor skills in basic medical procedures like insertion of chest tubes. There was lack of understanding about basic things like respiratory physiology and how to mechanically ventilate a baby. There was poor management of common neonatal conditions like hypoglycemia. There was lack of knowledge about commonly used equipment in the NICU like Neopath and capnograph. There was failure to protect infants who were at risk, for example, hemophilia, from trauma during intubation. There was a lack of teamwork and trust between the health professions. There were also statements given by many witnesses which point to serious resource and infrastructure deficiencies. And these specific concerns that were expressed by individuals include inadequate numbers of appropriately trained personnel in the unit, lack of training for assigned nursing roles, inadequate staffing and workload overload, poor plumbing and drainage resulting in the need for intensive cleaning in the unit. And this is a potential factor in Stenotrophomonas maltophilia infection because this particular bacteria thrives in water, and particularly in dirty water and bad water. There was poor environmental temperature control in the facility. There was difficulty in finding a doctor when the need arose. There was congestion at the medication cabinet and preparation trolley. There was lack of appropriate facilities for sterile preparation of drugs. Some high-risk infants should have been born and cared for at higher level institutions, but were born and cared for in this hospital. And there were delays in transfer of sick infants to higher level facilities when the need arose. So these are not things that we invented. These are statements given by people who worked in the unit. Our conclusions of this panel, therefore, was that there was no medical evidence to support malfeasance causing death or injury in any of the 17 cases in the trial. Now, I've only presented you 7 of the cases, 7 of the 14 of which there are convictions, but the others are similar. It's just nuances, changes of variation in the details, all right? Death or injury of all the affected infants were due either to natural causes or to errors in medical care. There were serious problems related to medical care of patients at this hospital. There were problems related to teamwork and interdisciplinary collaboration at the Countess of Chester Neonatal Unit. In summary, ladies and gentlemen, we did not find any murders. In all cases, death or injury were due to natural causes or just bad medical care. Lucy was charged with 7 murders and 7 attempted murders. In our opinion, the medical evidence doesn't support murder in any of these babies, just natural causes and bad medical care. Our full report will go to Lucy's barrister later this month, and then it'll be up to him in the courts to decide what next to do. So in closing, I'd like to thank you for attending this press conference. I hope our findings bring comfort and closure to the families of the affected infants, and our hearts and sympathies go out to them. I would like to thank Sir David Davis and Mr. Mark McDonald for their efforts, and Sir Davis in particular for graciously organizing and chairing this meeting. I would also like to thank the members of the international expert panel. They are some of the most experienced and best minds in neonatology in the world today, and they are incredibly busy people who have given freely and generously of their time to this effort to uncover the truth. And they have done so with objectivity and impartiality, knowing that regardless of whatever they say, whether it's favorable or unfavorable to Lucy, it would be released, because they did not come into this to free Lucy. They came into this to discover the truth. Finally, we hope the authorities will consider our findings seriously and act accordingly, because you will not find a better panel of experts anywhere in the world. These are the best in the world that you can find, and they come from the most prestigious institutions. They come from Boston's Children's Hospital, Children's Hospital of Philadelphia, Hospital for Sick Children in Toronto, Imperial College, Karolinska Institute, Ulm, Tokyo National Child Center, and so on. Right? These are truly the best. And today is actually a historic day, because it is possibly the first time that a group of the top minds in neonatology in the world have come together voluntarily and pro bono to provide clarity to some very vexing questions about a troubling case. If you are looking for the truth, you don't need to go any further. I'll be happy to take any questions.
Thank you very much indeed. That's an astonishing set of revelations. So thank you for that, and thank you to your panel, who have, as you say, given their time for pro bono. Now, can people identify themselves and their organisation? I'll go right across from right to left. Sir, you. Yep.
John Sweeney, podcast Lucy Letby, Was There Ever a Crime? Thank you. Thank you very much, Dr. Lee. Can you tell me, on the PubMed, how many publications have you authored?
In terms of peer-reviewed publications in journals, I've authored over 400.
How many peer-reviewed publications, according to PubMed, has Dr. Dowie Evans, the Crown's star expert witness?
I don't know.
The answer is 0. So, in simple footballing terms, we've all heard of Liverpool, we've all heard of Andover Town, and they both score goals. Here is the problem. You and your panel have written together thousands of peer-reviewed papers on neonatology. The Crown's star witness, Dr. Dowie Evans, has written 0. What does that tell you about the scientific knowledge of Cheshire Police, of the Crown Prosecution Service, the judge at the trial, and the judges at the appeal court, that they do not understand the difference between scientists who have published multiple papers on this subject and someone who has published nothing?
So, first of all, the panel that we have is, as I said, this is the top notch in neonatology. This is the creme de la creme, the dream team of neonatology. You're not going to find any better, right? And if they can't tell the truth, nobody else will. You can find all the people in the world, and they're not going to get any better than this. With respect to the Cheshire Police, I don't know. I mean, I don't know the police. With Dr. Evans, I don't know him either. And you tell me that he hasn't published anything. If you look at this panel, there's probably about 500 person-years of experience with all these people. These are the heads of units of the top institutions in the world. So I would trust their judgment. When it comes to Dr. Evans' testimony and his opinions, I would ask you to ask 3 questions. First of all, the first question would be, if our panel found so many problems with the medical care provided by this team at this hospital, how is it that Dr. Evans found none? Because in none of the 17 cases did he even identify one problem with the medical care provided at the hospital. The second question I would ask is this. He seemed to be rather selective in his use of information. So if he wasn't selective, if all the information was used, in fact, you would come to a very different conclusion than what he came to. Just take, for example, the case of the hypoglycemia, where he said there was no sugar for 2 hours and the blood sugar grows, therefore it must be insulin. In fact, he missed the one important value, which was at 1146, showing that the blood sugar, in fact, did not rise. So was he just careless, or was it deliberate? The next question that I would ask is, even when there's an obvious cause of death, why did he go around looking for malfeasance? So I would ask you to ask these 3 questions. and ask Dr. Evans that. If you can answer those three questions, I think you have the answer to your question.
Sir.
Archie's Josh Stannis. Can I ask Professor Nina Modi, with your experience of the BMA and well, colleges and the NHS, does this evidence point to yet another maternity scandal in the NHS?
Thank you very much. I want to make it quite clear that I'm here in a personal capacity. I'm not representing any organisation, not the BMA, not the RCPCH or any other organisation. What we have shown is, as Professor Lee has outlined to you, that there were plausible reasons, very, very plausible reasons for these babies' deaths, and that there was a combination, if you take the totality of the 17 cases, there was a combination of babies being in the wrong place, delivered in the wrong place, delayed diagnosis, and inappropriate or absent treatment. It was not our brief to comment on the wider issues facing the NHS or on other maternity reports that have been issued recently. But I would say to you too, there are clearly systemic factors that are at play that we've identified, as well as individual factors which we have also identified.
Yes.
Thank you very much. Jeannie Essen from Denmark Public Broadcaster. So David Davis, I wanted to ask you a question. Looking at all this together and the conviction, what does that tell you about the British justice system and what the evidence you're looking at today? And also, where does the case go from here? Where could it go from here? She's lost a bit to appeal, of course, we all know that. So where could it possibly go now?
First, the British judicial system. Back in 2011, the Law Commission published a report challenging the handling of expert evidence in court. Who appointed it, who paid it, how they selected it, and so on. This case is a case study in why that report should have been implemented. It hasn't been, and it should be now. Secondarily, there is currently a Law Commission investigation into the basis of conceding appeals, of allowing appeals, sorry, not conceding appeals. That too, I think, is necessary, overdue in fact, and we need to reconsider the basis on which we accept or define evidence as new for the purposes of appeals. At the moment, as I said in the debate in Parliament, at the moment, if you were unlucky enough, if your lawyers, for whatever good reason, tactical reason, did not deploy a piece of evidence and you tried to use it later, you can't. So if your lawyers make a mistake, you're banged up for life, hard luck, you know. That's not justice. It may be judicially convenient, but it's not justice. Sorry, what was your last question?
Where the case goes from here?
Well, that's really a question for Mark.
Oh, it is.
Yeah.
Hello, hi. So, Criminal Cases Review Commission have the application. They will be waiting eagerly for the report, which is going to be coming at the end of the month. Then it's up to the Criminal Cases Review Commission to decide whether or not to refer it back to the Court of Appeal. What you've just heard and what will be in the report is overwhelming evidence that this conviction is unsafe and must be immediately referred back to the Court of Appeal. So we will be waiting patiently for them to make that decision.
I, for one, find it very hard to understand how they cannot refer it back on the basis of what we've heard today. Yes?
Tessa Chapman, flying news. To Mr. MacDonald, have you discussed these findings with Lucy Letby herself and what was her reaction?
You know, what I have done since I've instructed is not talk about Lucy and not talk about where she is and what she's doing. I've focused upon the issues in relation to an unsafe conviction. But she has hope, and that's all I can say.
At the back there. Yeah. Sir?
Hi, Josh Halliday from The Guardian. Can I just ask, how many of the 7 deaths do you think were preventable?
That's a tough question.
You know, deaths are often multifactorial. And sometimes even when you do all the right things, death occurs. That's just life, right? So if you say, could we have prevented these deaths? I can't tell you for sure which ones we can prevent. What I can tell you is that the appropriate treatments were not given. And would May some babies have survived because of it? It's possible. I cannot predict which baby will and which cannot.
Yes.
In terms of
Name and company.
sorry, Anouk Curry, freelance filmmaker.
Yeah.
In terms of potential clinical negligence, is it possible that this could be investigated now, and this is a question for David Davis, Sir David Davis, while the whole trial and potential appeal are ongoing? I mean, where do we stand with this? We're hearing some very damning accounts.
Yeah. Our principal aim is not pursuing clinical negligence, it's pursuing justice. And what all of this does is provide a completely alternative explanation for the deaths and collapses of those children. An explanation which, in my view, should have been exposed at the trial, not now. So that's really our only interest. Justice generally, both for Lucy, but also for the parents of the children who must have a terrible cloud hanging over them.
Is this the first that the parents would have heard about this?
I would imagine so. Yeah. I would think so.
don't know.
Yeah.
Yes, yes.
Yeah. Nadine.
Dr. Lee, between June 2015 and June
Microphone.
2016, the Countess of Chester neonatal unit was a level 2, which attracts substantial additional funding from the NHS, which means it takes high-risk patients. Is it your opinion that the Countess of Chester should not have been at a level 2, therefore taking those high-risk babies? Should it have been at a level 1, which it was later downgraded to? And do you think that with all that you've said about the physicians and the doctors who were working on the unit at the time, that those doctors at that unit for a level 2 did not have the appropriate level of qualifications and experience to be able to operate and treat those high-risk patients?
So I'm not familiar with the NHS, so I'm going to punt this one over to Nina.
So there are 3 levels of units, as you know. There are neonatal intensive care units, local neonatal units, and special care baby units. And so levels 1, 2, and 3, or 3, 2, and 1, I should say. And the Countess of Chester was, as you say, a level 2 unit at that time. Now, a level 2 unit operates within certain general guidelines. They will accept babies of a certain category, and they will not accept, or they will try and ensure the delivery of babies who they're not set up to deal with in a tertiary centre. That requires collaboration, cooperation, discussion between obstetric and neonatal teams. So I think the first point I would make is that there is a legitimate question to ask. Did those conversations take place? And were babies born at the Countess of Chester who should probably have been born at a level 3 neonatal unit? So the point I want to make is that medicine is a continuum, it's a team effort, and things can go wrong at multiple places. But were those questions asked? Was that discussion held between obstetric and neonatal teams? And should some of these babies not have been born at the Countess of Chester? Your second point relates to qualifications. I think here one wants to draw a distinction between qualifications and experience. And self-evidently, a level 2 neonatal unit is not going to have the throughput that a major tertiary centre is going to have. So the staff, no matter how well trained, no matter how competent, no matter how appropriately qualified, will simply not have the experience because they're not seeing that flow of patients through the unit. So sometimes in level 2 units, the staff are forced to look after babies, because babies have been born there, forced to look after babies who should not have been cared for. This is no criticism of them. They are doing the best they can under the circumstances that are presented to them. So that's a second consideration. The third is that, as we all know, the NHS has been under great strain, staffing has been a problem, and many, many, many neonatal units around the country, including the Countess of Chester, have had staffing issues and have not been able to fill their rotas appropriately. So I think what I'm saying is that all of the above, but they're all weighing in different ways in each of the cases that we've discussed.
It's also notable that they downgraded the day they suspended Lucy, which tells you something as well. Yes, ma'am. Second row. Yeah.
Hi, I'm Caitlin at PA. A question for Mr. MacDonald. You mentioned today deaths due to natural causes, bad medical care, inadequate staffing, etc., etc. These were all themes that were explored extensively by the defence at the trial. Examples relating to baby 4, baby 11, about potential issues with the air leak. So my question to you is this just a rehash of the defence case rather than new evidence?
The difficulty is, if you do not have an expert at a trial, then what you ask of an expert in cross-examination is not evidence. You can put whatever you want to a prosecution expert. They don't accept it. The judge will sum up to the jury the evidence of not accepting it, not the evidence of putting the question. And the defence did not call an expert. So as a result, all you were left with was the evidence of prosecution experts in relation to neonatology, paediatrics, and pathology. And so, yes, this is fresh evidence. This is new evidence. It's compelling evidence because of the nature of the people who are giving that evidence. And it wasn't heard by the jury.
Yes, ma'am.
Okay, that's okay. So Phoebe Davis from Tortoise Media. Dr. Lee, I'm just struck by you have personal involvement in the case because your evidence was used. As far as I'm aware, the other experts did not have any personal involvement in this case. I'm struck by them coming together, as you say, in a historic way. What is the impact of this case on the international community in this sector? And I'm curious as like why does this case matter? Why do you think it's taken up so much attention? I guess this is also for Dr. Moody. Why does this case matter so much to the profession?
To be honest, I'm not sure how much of this case gets around the world. This is UK news, and it may be on the headlines in the UK, but in Canada, I didn't hear very much about it. I saw a little column in the newspaper about that big, saying that a nurse had been convicted in the UK for 17 murders, and I thought, how terrible this is, and that's all we hear. I think then what happened subsequently was that I was called by the defense for the appeal to say, can you look at this? And I don't usually do medical legal cases, I just don't enjoy them. In this particular case, because they used my paper, I was curious to see what exactly did they use my paper for. And when I saw the evidence that they gave, I was disturbed because it was wrong. And after I gave the appeal, I realized that she had no further road to go because she had exhausted all avenues of appeal. And yet, it remained that the evidence was wrong. Now, I didn't know at the time whether she was innocent or guilty. What I did know was that the evidence that was used to convict her was wrong. And to me, that's a problem. You shouldn't be using wrong evidence to convict someone, regardless of whether she's guilty or innocent. And so that was when I decided to have a further look at the evidence, because it wasn't just about the skin discoloration, which was asked at the appeal, but it was about many other things. And without looking at all the other evidence, I couldn't form any opinions. And that was when I approached the solicitors at the time to say, well, if you are willing and if Lucy is willing, I'd be willing to look at the rest of the evidence. And if I was concerned that the rest of evidence was also a problem, I would convene a panel. And so we did. And as you can see, these people on the panel are not ordinary people. They are not just ordinary neonatologists, that you get in the street anywhere. These are the best of the best. And the reason they came was because they were all interested in the truth. And these are people of high integrity, and they want to make sure that things are done right. And so they came, and Nina is one of those. Nina is, a good friend of mine for many years, and she's one of the most respected neonatologists in the world. And so are all the others, right? So they all came and they volunteered their time and services to be part of this and to look at what the evidence is, so that we can get some clarity on this, and that this can be hopefully resolved.
I'd like to ask two questions. The first is to Sir David Davis. At the moment, there is a public inquiry sitting. It's predicated on the assumption that Lucy Letby is guilty. From what we've heard today, which I may say is the most devastating presentation I have ever heard in a miscarriage of justice case, and I've covered many over several decades, this inquiry is entirely based on a false prospectus, and I wondered what you think, Sir David, should now happen to the Thirlwall inquiry. Should it simply be wound up pending the hearing the appeal? My second question is to Dr. Lee. It was in fact Sir David who in the House of Commons last month who disclosed that in 2 of the cases of which Lucy Letby was convicted of murder, the people who committed acts of what one might euphemistically describe as poor care, including puncturing the liver in the last case that you highlighted today, went on to become principal accusers of Lucy Letby. They were instrumental in helping the police with their investigation and then gave evidence against her. I wonder if you would like to comment on the fact that people who, from your analysis and your panel's analysis, themselves were large contributory factors in those deaths, went on to accuse her.
I'll take the first bit first. I mean, firstly, it's not part of my role to critique the Thirlwall inquiry. I'll just say the following 2 things. Number one of the failures we're looking at here, we're looking at a number of judicial failures, a miscarriage of justice, and a failure of the health service to mark its own homework, if you like, to decide what it got wrong and what it has to put right. And as a result of that, I wrote to Lady Thirlwall before the inquiry sat and suggested to her that she might get a more accurate outcome of her inquiry if she left at least an opening in her mind that Lucy may not be guilty and that there may be other causes for these deaths. It's the second part in the context of the Thirlwall inquiry that matters most. That if we can't fix the health service when it gets things wrong, there'll be future babies that die unnecessarily. So I wrote to her and I got an answer. It's a dead bad answer. It's what I'm used to getting from ministers mostly. So it's not for me to critique it, but I think when it comes down to it, the judicial system will, I hope, end up overruling what the Thirlwall inquiry concludes. So, you wanted to answer his point?
I don't think I can answer that question because that's something that you have to ask the people who are involved. I can't ascribe motives to people. It is possible that perhaps they don't even have insight into their own lack of expertise in these areas. And so I would recommend that they take a close look at the report that we have written and to see for themselves where they have deficiencies and what they need to do about it.
Okay.
There's
yes. Well, no, here. Sorry. You can't just grab the microphone.
Hi, thanks, Phyllis. Felicity Lawrence, formerly for The Guardian and freelance still for The Guardian. There were many experts who were really troubled by this after the convictions, and then there was more charges, the press were silenced for over a year. Where could you have gone, Professor Modi, with your duty of candour? And where could other people have gone when the court and the legal system treats your concerns as contempt? There doesn't seem to be any way of raising the alarm at the right moment. Do you have any thoughts on that?
I hope that the process that we've seen unfolding, of which today is a major part, has actually demonstrated that there is a route to be followed, there is a process to be followed in these sorts of circumstances. I, like many of my colleagues, followed the trial as it was written up in the newspapers and did not know any more than that until several journalists sent me more detailed information about the cases, and what each of these pieces of extra information that I read raised my concerns even more. But it was only when I was instructed by Mr. MacDonald and his solicitors that I read the full papers, and my anxieties were hugely amplified, I have to say. So it's been an evolution. I should also say that I did raise my concerns with the defence team. I had a courteous reply, but No, not during the trial. During the trial, but nothing further was asked of me. So I think you ask a very legitimate question. We do have a duty of candour, and it can be very difficult sometimes to know where to go when one has concerns about how to exercise that duty of candour.
Dominic Ashani,
No, wait. I'll just make one other point, and that is that during the course of this process, mostly post-trial, there have been a number of people get in touch, principally nurses, who have been afraid to come forward because they've seen what's happened to whistleblowers in the health service historically. And so I think it's wider than simply the experts.
It is. May I just come back briefly on that?
Yeah.
Because we have had previous discussions, national conversations in this country about the need to learn, to have a learning healthcare service. And I think the legal process here with its adversarial process does not serve patients well. What we really needed in this instance, way back at the beginning of these cases, was a really in-depth investigation conducted by medical experts, not just neonatologists, but also pathologists, clinical chemists, surgeons, obstetricians, and so on and so forth. Had we had that done at the outset, then perhaps we would not now be in the position in which we're in.
And ideally on a no-fault basis.
Yes, Dominic. Can we take Dominic?
All right.
He's got to go.
I'll give in to your pressure.
Broadcast headlines. Dominic Ashani, BBC News. The prosecution approached this case not just on the basis of the medical evidence, of course, that is at the heart of it, but also wider, what they said was circumstantial evidence about Lucy Letby's behaviour, what she did afterwards, the fact that she kept mementos, various other things. How do you address that wider case, which was presented to the jury and left them sure of her guilt?
Let me deal with that head on. First of all, Lucy Letby was convicted because of the medical evidence that was presented to the jury. Medical evidence led by the lead prosecution expert, Dr. Derry Evans. If that evidence was at fault and was wrong, the conviction is unsafe. It's as simple as that. The other parts of the evidence that you talk about, the circumstantial or the lesser circumstantial evidence, falls away. Now, we can go through each one of those if you want. There is a valid explanation for all of them. But the most important thing, the reason why Lucy Letby was convicted was because of the evidence, the medical evidence that was presented to the jury. That today has been demolished.
Medical and statistical evidence, before you leave, and the statistical evidence has also been demolished in a different context by equally senior and authoritative people. The other thing you're seeing is a very large element of confirmatory bias. That was apparent to me when I went through the trial on a day-by-day basis, that they started out by persuading the juries that she was guilty on the basis of statistical and medical evidence, and then everything that followed on was interpreted in the worst possible way. Dr. Hammond.
Dr. Phil Hammond, Private Eye. Jeremy Hunt, longest-serving health secretary, in his book Zero, estimated perhaps 1,000 babies die in the UK every year who wouldn't die had we had the same standards of neonatal and maternity care as Sweden. I'd like to ask Dr. Lee, did any of the international experts look at this and go, gosh, this could easily happen in my country? Or did they say, God, what an appalling system the NHS has, this is the tip of the iceberg, thousands of babies must be dying avoidably from substandard care?
We only looked at 17 cases, so I cannot speak about the NHS, really.
Could it happen in China? Sorry, could it happen in Canada? Could it happen in China too? Could it happen in Canada?
Well, we hope not, because...
Why not?
Yeah. I would say that if this hospital... We also have a level 1, 2, 3 standard in our hospital, similar to the UK. We are, after all, a British colony previously, and a lot of our systems, were built on the British standards. I would say that if this was a hospital in Canada, it would be shut down. It wouldn't be happening.
About 25 years ago, after the Shipman report, there was very briefly, because I was involved in it, an attempt to encourage a no-fault analysis of health service failures on the same basis that airline pilots and airlines are reviewed after a failure, after a crash, after a near crash, whatever. It sort of precipitated enthusiasm for about 6 months and disappeared. The health service didn't want to play. I think there's an argument for that right now. Yes, sir.
Peter Hitchens, Mail on Sunday. Have you sent, or do you propose to send copies of this report to Dr. Dowie Evans, to the Thirlwall inquiry, and to the Chief Constable of Cheshire Police, who still apparently intend to continue interrogating Ms. Letby?
The owner of the report, yes.
This is a summary of the report. The full report is going to be coming at the end of the month. And the privilege, as in the legal privilege, is that of Lucy Letby. And if she gives consent, I've already suggested that this is a report that the families may want to see as well, which I think should be on the top of the list. You know, it's not my job to send it to the prosecution experts. One hopes that given it to the Criminal Cases Review Commission, they might disseminate it to those that gave evidence before the jury. I personally, to answer your question, won't be in contact with Dr. Dowie Evans to give him a report.
Right. Here, and then we'll come back over here. Yeah.
Paul Brandt, ITV News, thank you. I appreciate it takes a bit of gumption to come out and talk about this publicly, and I wonder what kind of weight there has been on all of you actually. The CCRC say in its statement today that those speculating about the case only have a partial view of the evidence. How sure are you that you're on the side here of an innocent woman and not a serial killer?
Before I let the others answer, this first came to my attention because of a New Yorker report, 13,000-word report, a very thorough one, which was suppressed by court order when the second trial was going on. So I raised that matter. The result of that was I had the most authoritative group of people I've ever had in my life communicate with me. They're past president of the Royal Statistical Society, past president of the Royal College, a whole series of professors, forensic experts, people who knew what they were looking at. And each of them said to me the same thing, or similar things. They said, my bit of this is wrong. The bit I understand, the statistician said, I can't speak for the medical evidence, but the statistics is rubbish. It's misleading. The medics said we can't talk to the stats, but the medicine is nonsense, the forensic and so on. And so that was the first thing. But that told me it was a mistrial, not it was a miscarriage of justice. So I spent the next 3 months immediately after the election, this bracketed the election. Immediately after the election, I spent the summer. I wanted to get the transcript, but I was told that would cost £100,000. So, and I didn't have £100,000 to hand. So I went through the daily reports every single day of the trial, right, to see if there was a clear-cut, single charge against Lucy Letby. Because if she was guilty of one of them, I didn't want to know. I was interested if it was a miscarriage, not if it's simply a mistrial. I'm not interested in judicial games. And I got to the end of it, and none of it showed clear proof of anything. None of it showed actually that a murder had occurred, let alone that she was witnessed carrying out any improper act. And so at the end of that, with the greatest of respect to some of the people criticising this, I think I've spent more time on it than they have, right? And those who say, well, you weren't there, I've been through every single day, and now I do have 3/4 of the transcript, and we've been through that too. So I'm afraid I've probably looked at it more than the appeal court judges, in terms of time and commitment, and I'm a scientist and mathematician by training, and that's what matters in this, not the law, frankly. So that's my answer to that. Anybody else want to answer? No?
Apparently, as independent members of the bar, we're not allowed to say that our client is innocent. But can I say this, that there is overwhelming evidence that the conviction is unsafe. And if Dr. Shuley and the panel are correct, no crime was committed. And if no crime was committed, that means that a 34-year-old woman is currently sitting in prison for the rest of her life for a crime that just never happened.
Sorry, over here. Yes, sir. and then you.
Thank you, Sir David. Edward Abel-Smith, co-host of Was There Ever a Crime? The Trials of Lucy Letby. My question is with regard to the CCRC, the Criminal Cases Review Commission. If we look at cases such as Andy Malkinson, who has his conviction overturned, or Robin Garbett, who's awaiting his outcome from the CCRC, these things can take 5-10 years to get to the appeal court. Is there anything you can do, or is there anything you're going to do to try and ensure that Lucy Letby isn't still waiting for her time in front of a retrial for another 10 years, say?
I've been working with the Criminal Cases Review Commission for over, I think, 20 years. And some cases I've had in the CCRC for over 7 years waiting for them to make a decision. Currently got one that's 8 years, I think. But what I do know is that the CCRC are taking this very seriously. They've already got a team in place. They're ready to go. And I hope that having... Because they've watched this conference. I've made sure they've had a link to this. They've watched the presentation. They've got this report. They're going to get the final report. That they've seen what you've all seen. I'm hoping they're going to take this very seriously and deal with it very quickly, and we will be back in the Court of Appeal very soon.
So,
Joshua Rosenberg, a lawyer rights on Substack. Question for Mark MacDonald. You said, you drew attention to the fact that the defence didn't call any expert witnesses. Now, you're not going to say anything critical or otherwise about the previous defence team. But that's a mystery in this case. Am I right in thinking that this is all a question of professional privilege and that your client could allow them to speak, that she could tell you how it was, that her advisors didn't call the expert evidence that you clearly think they should have called previously?
You're absolutely right, but that doesn't answer the bigger problem that we face. The bigger problem that we face is what Sir David Davis has already identified, is the Court of Appeal test for adducing fresh evidence. That threshold is quite high, and one of the rules against admitting that evidence is whether or not that evidence could have been available at the trial. And so that means that even though a conviction is unsafe because we've got overwhelming evidence here, the court has a discretion to deny all this evidence to go before it because Dr. Shuley could have been called at the trial and wasn't contacted. You already heard that Dr. Modi was actually herself contacted the defence team at the trial and wasn't used or wasn't asked or certainly wasn't engaged with. Look, my job is not to dissect the decision-making of the trial defence team. Lucy Letby was represented by an experienced King's Counsel, had excellent solicitors. I have to start in September, as I did when I was instructed, with a clean slate and say what went wrong here, having identified that, found out what I can do in relation to identifying those experts that can deal with those issues. And I'm so grateful to Dr. Shuley and the panel for coming forward and providing what they have done today. It is now up to someone else to decide whether or not they want to deny that evidence, refuse to accept that evidence, and not allow it to make the conviction unsafe, or hear it.
Right. Over here, since we're here, and then we'll come back to Nadine. Yeah.
Hi, Natasha Clark from LBC. Sir David, obviously Keir Starmer is the former Director of Public Prosecutions. Do you think that the DPP have questions to answer here, and have you got a message for the Prime Minister? And do you think there's a case to look again at jury trials in specific cases like this, where there's a lot of medical evidence, which is clearly incredibly difficult for ordinary members of the public to try and dissect? Thanks.
The answer is no and no. I don't suppose the DPP worried about this. In fact, it's after his time. In terms of jury trials, we are not, by law, allowed to interview jurors in this country after the event. The only example I know of where that was broken, as it were, was when the Jubilee line case was dismissed. And it was widely thought at the time that the jurors in the Jubilee line case couldn't understand its incredibly complex financial comings and goings in that case until they were interviewed, when it was plain that the jurors understood it better than the lawyers involved in the case, which I suspect was true here too. Right. Nadine, sorry. Yeah.
Nadine Jones, I should say I was the Health Minister responsible for maternity and neonates for 2 years, and I saw a number of investigations into a high number of neonatal deaths in the UK. But my question to you is, you said at the beginning of your presentation that it's quite complex, and there was a panel of you and there was a huge amount of detail to look at. Lucy Letby sat in jail for 7 years while Dr. Dewey Evans prepared his reports. We believe that he was paid a substantial seven-figure sum for doing so. Do you think it was appropriate, and this is probably one for Mr. Modi as well, would it actually take 7 years to have compiled those reports to take to court in 2023, during that time whilst Lucy was sat in prison?
That's tragic. 7 years is a long time in anybody's life. I would hope that something is done about that. I don't think that, in my own personal opinion, that seems very long. I don't know about the court, so I can't speak to that. It's just tragic. I cannot even imagine how that happened.
Can I come back on the issue in relation to jury trials, if I may? I am a big supporter of the jury trial and would not like to see it go in any way whatsoever. However, there's a layer before this ever getting to a jury, and that's the one that Dr. Modi identified. That the complex science and the complex should have gone out to the leaders in the field and discussed it and assessed it before it got anywhere near a criminal charge. In this case, the lead prosecution expert, who was a retired paediatrician for 15 years and was a professional expert, described in a podcast how he contacted the police, how he jumped in a car, drove to a police station, how he says, was handed a set of notes, and within 10 minutes, whilst drinking a cup of coffee, he identified that the baby had been murdered. And that was the start of a process. That was not the way to start this case at all. It should have gone out to experienced, highly experienced neonatologists and pathologists before it got anywhere near a criminal charge.
Gentleman at the back.
Stephen Phelps, I'm a retired television producer. I used to make BBC's Rough Justice and Trial and Error on Channel 4. I'm picking up on the point about Dowie Evans, the Crown's principal expert witness. Are you aware that he did not actually hold a license to practice during the relevant periods? His license to practice ran out in 2014 and was not renewed again until 2019, which means he was not licensed to practice while the events were happening, nor when he was writing his reports for the police in 2017 and 18. And the Academy of Medical Royal College's guidelines say that healthcare professionals giving expert evidence must hold the appropriate license to practice and be in or sufficiently recently in practice. And as we know, he hadn't been in practice for many years, and now we know that he didn't hold a license at that time. Does that make him a totally unsuitable expert for the Crown to have used?
Well, I mean, I don't want to comment too much about his background or his experience. The Crown Court judge, the trial judge, found that he should remain, and the Court of Appeal upheld his qualifications to be an expert. So it's not for me to say now that the Court of Appeal are wrong or that the trial judge was wrong. In relation to should he been allowed to have been an expert. My understanding is, in fact, that his expertise was never challenged at the trial, at the start of the trial. It was many weeks in when the trial judge received a email, I think it was, from another Lord Justice of Appeal raising concerns about Dr. Dowie Evans. And then there was a large argument about whether or not they should continue, and the judge decided after legal argument that they should continue. It's a very long answer. What I'm trying to say is that the trial judge found that he was an expert and able to give expert evidence before the jury, and so did the Court of Appeal. If issues like this were canvassed, one would have hoped that the judge would have taken that into account.
But it does bring us back to the Law Commission report back in 2011, which we should implement. So, you are trying to get my attention? Yeah.
Dr. Roger Norwich, a question for Professor Modi. I'm a doctor who, amongst a group of other doctors, have been very concerned about the quality of the medical evidence that was given in the trial, so much so that we made complaints against the two main expert witnesses to the General Medical Council. The General Medical Council completely refused to engage with our complaints and have continued to ignore us. Can you tell us what you feel this tells us about the regulation of the medical community and what it tells us in terms of patient safety?
Thank you. I was asked to give a written statement to the Thirlwell inquiry, in fact more than one written statement, and I did make the point in one of those statements that it would be advisable to give some consideration, some scrutiny to the ways in which medical experts or those professing to give expert evidence at trials, how their competence to do this is assessed. So thank you for making that point. I have raised a similar point.
Right. I think the last. Yes, sir. Again. Yeah, go on. I think there's nobody else.
Okay. Dr. Lee, can I ask you, this morning there will be parents who have some closure to their baby following Lucy Letby's conviction. If we just look at the first chapter in Revelation, some of these deaths could be preventable. What would you say to these parents this morning? And if they were to reach out to you, would you make your evidence available to them?
I think that's something for council to work with. So we'll be giving our report to the barrister, Lucy's barrister, and I think I'm sure he has the wisdom to know how to deal with that, and I'll take his advice on how we proceed.
From that, just deal with that. Obviously, it's covered by legal privilege, and so consent has to be given by the client when disclosing it to someone outside an official body like the CCRC. But what I do know is that Lucy, in her, has constantly said and felt sorry for those parents that have lost children. Now, she was convicted of the murdering of those children, so that probably doesn't really weigh too much on them. But if Dr. Shuley is right and the panel is right and she is innocent, then I'm sure she'll want to make sure that the parents know the truth of what went on.
Okay, last question because we're running out of time. Sarah Napton.
Thanks, David. Sarah Napton from The Telegraph. A question for Dr. Lee. If the prosecution had come to you and said that they were planning to use your work in the way that they did, what would you have said to that? And might air embolism cases have been nipped in the bud if they'd done their due diligence early? Could we have prevented it getting this far?
The answer is yes.
Right, can I say thank you to the panel? Thank you to everybody for coming. This is the longest press conference I've ever chaired. Thank you very much.
And those who don't have reports, there should be some more left behind here, so if you want to grab one, please do.
Thank you. Brilliant.
drunk a lot of. The full battery in there, but still plugged in. This is the electrical plug. So I'm not gonna use that. But yeah, so we would zoom in. So normally the zoom is the back of the focus. Okay. The zoom is the front. The focus is the back. So you can function like this. And this one's already out here. So this is the widest that we get. Like that. And this is normally we won't be cycling between public zones. So today, for example, we'll use a process. And then another the one thing I did struggle with, the screw is not fully, like I couldn't tighten up my arm going left yesterday. I tried to get close to the but I couldn't, because it's going to take like care to get the screw out, just because it's so I'll try to replace it this evening. But because I was trying to get it live, I was like, you know what, I'm just going to break a little bit. So it'll shift. But that'll be fixed. The one thing I noticed because on the normal plate, you can take this up so alright, well that improved it a little bit. But yeah, I have found that I have to let's say we're zooming in on these guys all the way in. So look, that's how high I have them. Top of the boat was at the top of here. Like the top of the boat, cutting at the top of the monitor. The sensor on this is really sensitive. As in, like, you can be standing right here and that shadow can stop. So I changed it to my own. Yeah, so you have to bring it off around the just because otherwise this is almost impossible. I have it at the expression. I'm going to leave the expression on the stage. I have it that's great. Otherwise it will stay shot. So I always do expose. So it's easy. Okay, so that's the okay. That's the your health is the you can see it. Look at that. See that it's to the right of it. So it's basically, it's this little lever right here. Flip it forward. And you have to, this little, what you can do is push it on just a little bit. Flip this down, and then okay. Just to, there's a, you don't have to worry about that. Just when you flip the button, so right here when we get close to check, and it's like, alright, it's another one.
¿Sabes esa parte? Ahí está.
salvage crews, but they're paying us divers work on the water, as shown by the diving. Global diving community.
Con esas palabras que me dijiste, lo estructuro y lo hago.
Sí, o sea no está perfecto, pero...
No, pero puedo estructurar la
Sí.
parte de puentes en el capsule y coloco la información de la bandera.
Sí. Sí, porque la foto que es la bandera.
Claro, ¿cierto?
Sí. No, nosotros no podemos ver abajo. O sea, nosotros como no podemos ver abajo.
Ah, ok, claro.
Eso es lo que nos dice que está pasando en la tabla. Está bien, o sea, es como se ve, esencialmente. Si era la cámara la que estaba diferente. Porque, por ejemplo, o sea, no sería algo así ni sincero porque sí lo es, pero no creo que es lo que está haciendo la diferencia. Sí, Lieutenant Wishes.
2 inne i lokalerna på skolan. Ett antal skadade personer har anträffats med skottskador. Och en av de här skadade personerna är en person som vi misstänker kan vara gärningspersonen. Vi har i nuläget inlett en förundersökning på försök till mord, mordbrand samt grovt vapenbrott. Framåt kommer vi även givetvis att fokusera på ett trygghetsskapande arbete. Det vi har gjort hittills är att vi har inrymt även ett flertal andra skolor med anledning av att vi är, som regionpolischefen sa, i en pågående insats och något oklart läge initialt. Och vi har inrymt vi har inrymt 6 stycken skolor och ytterligare en restaurang i närheten. Successivt så håller vi på nu att tömma de skolorna i takt med att våran lägesbild klarnar. I nuläget så vill vi inte ha allmänhet eller andra personer till platsen i och med att det är en fortsatt pågående insats. Och vad det gäller just att uttala sig mer kring gärningspersonen så är det i nuläget väldigt tidigt. Vi är i en pågående insats så att med tiden så kommer det och säkert att klarna. Men vi jobbar väldigt intensivt just nu. Och det är den informationen som jag tänkte lämna kring vad vi vet just nu.
Ja. Ska ställa mig då. Ja, Jonas Claesson heter jag, hälso- och sjukvårdsdirektör i Region Örebro län. Jag tänkte berätta lite grann om läget i hälso- och sjukvården kring den här skadehändelsen. Som Roberto sa så inkom det ju larm strax efter 12:30. Vid 1-tiden gick regionen upp i förstärkningsläge, eller rättare sagt i stabsläge. Vi inrättade då en särskild operativ sjukvårdslinje för att kunna hantera den här händelsen. Det innebär att vi snabbt försöker skaffa fram mer vårdplatser, mer operationsutrymme och mer intensivvårdsplatser för att kunna ta hand om ett stort skadeutfall. Så här långt har 5 personer införts till akutmottagningen på Universitetssjukhuset i Örebro. Av dem så har 4 opererats, 2 är färdigopererade och stabila. En av dem som opereras är allvarligt skadad. Och den personen som inte har opererats är lindrigt skadad. Det är det skadeutfall vi har just nu och precis som Roberto påpekade så är det en pågående händelse. Det är den information vi har att delge nu. Vi vet, i och med att det är en pågående händelse, att vi kan få ta emot flera skadade och vi har goda resurser att ta hand om fler skadade. Vi har åtminstone ett 10-tal intensivvårdsplatser lediga och kan ta hand om 7 stycken skadade samtidigt på akutmottagningen om så ska vara fallet. Vi har också fått erbjudande om hjälp från Region Värmland, Region Västmanland, Region Uppsala samt Region Östergötland som alla kan erbjuda intensivvårdsplatser, ambulanshelikopterresurs som så behövs eller traumateam. Vi känner alltså att vi i nuläget har en god förmåga att hantera händelsen. Vi har också förstås dirigerat om vårdhändelser till andra delar av regionen än just Universitetssjukhuset på Örebro som en del i det förberedande arbetet. Vi har också gjort så att vi har upprättat en möjlighet att ringa in till växeln om man vill veta om ens anhöriga är omhändertagen på sjukhuset. Man kan då få veta om den anhörige finns på sjukhuset eller inte. Det är den informationen vi kan lämna ut. I övrigt så har vi också gjort så att om man är anhörig till någon som är skadad så har vi upprättat en mötesplats inne på sjukhuset där det finns personal som kan ta hand om en. Bomansonsalen inne på Universitetssjukhuset. I nuläget så tänker jag att det är vad jag kan berätta. Tack.
Ja, från kommunens sida så ger jag ju inga siffror eller annan bedömning än det som har sagts här kring utfall och lägesbild. Det är väldigt viktigt att vi agerar på vår gemensamma lägesbild och vi försöker förstå den så gott som det går och vi jobbar som sagt tidigare här väldigt tätt tillsammans. Vårt fokus är nu att värna verksamheten och inrätta ett gott krisstöd till de som är berörda. Vi har upprättat 2 platser för krisstöd i närområdet, Haga kyrka och nära en lokal Myrorna på väster. där man kan få all den stöttning och hjälp som vi kan ge i det akuta skedet. Vi fick informationen i samband med händelsen. Vi larmade då ut till föräldrar via våra elevsystem att inrymning har skett. Vi har inget annat skäl att tro än att vi har följt de rutiner vi har för sådana här händelser. Att inrymning har skett och att vi har lyckats hålla människor borta från platsen som annars kanske skulle dykt upp där. Vi har samband med polisen och övriga verksamheter upprättade. Vi följer läget och upprättar staber i våra verksamheter. Vi kommer att gå ut med kommunikation fortlöpande på vår hemsida. Våra servicecenter är aktiverade och där finns bakjour där verksamheten kan svara på fortsatta frågor. Så följer vi utvecklingen och tillsätter det stödet som kan tänkas behövas framöver. Och det är väl det jag kan säga nu från kommunens sida.
Ja, om det finns frågor så bara ställa om och då får den som svarar ställa sig rätt på skitan.
Ja, det cirkulerar väldigt mycket uppgifter om att det ska vara några som är döda, men det är inget som ni nämner nu. Kan ni säga någonting om det är någon som har avlidit?
Nej, men som jag sa så är ju det en pågående insats. Vi håller precis på att söka klart den aktuella skolan och av den anledningen, i och med att det också är en pågående förundersökning, så kan vi i nuläget inte uttala oss om just den frågan om hur många eventuella avlidna vi har.
Och vet vi någonting om offren? Kan ni säga något om ålder? Är det elever? Är det lärare?
Jag har ingen uppgift om det kring ålder eller om det är så är elever eller inte.
Kan vi säga någonting om skadeläget på den misstänkta som säger att de var bland de skadade?
Nej, men även där så kan vi i nuläget inte uttala oss mer än att det är en person som vi förmodar skulle kunna vara en gärningsperson.
Men säger ni att den är skadad eller skjuten?
Nej, men det är en person som är skadad. Men vi kan inte gå in på vilket sätt eller vilken omfattning då.
Det är en av de som har opererats, en av de 4.
Det är ingen uppgift jag har.
Har ni någon uppfattning om källan till den rökutvecklingen du nämnde?
Nej, det har vi inte.
Kan vi säga någonting mer om händelseförloppet? Det börjar med en skjutning utomhus och sen så kom branden och sen fortsatte skjutningen. Kan vi säga någonting mer om det?
Jag kan tyvärr inte ge någon närmare beskrivning mer än att vi fick larmet och vi kom till skolan och kunde konstatera att skottlossning hade ägt rum. Om det så var inomhus eller utomhus, det är uppgifter som jag tyvärr inte har i nuläget. Vi utesluter inte att det finns fler misstänkta. Och det är också någonting som vi jobbar i det fortsatta intensiva skedet nu. Att försöka ta reda på varför det har hänt och om det finns eventuella flera gärningspersoner. Och det är också det som är en av anledningarna till varför vi valde att inrymma några ytterligare skolor med tanke på det oklara läget.
Kan vi säga någonting om den här misstänkta? Har han själv gått på den här skolan eller han personen?
Nej, men först och främst så sagt, det är ju en förmodad misstänkt. Det är ingenting som är klarlagt än, utan det är en utredningsåtgärd som vi givetvis håller på och tittar i detta nu på. Att försöka klarlägga vad det är för person. Ja.
Den här misstänkta gärningsmannen, har någon anknytning till skolan?
Det vet vi inte i nuläget, utan det är någonting som vi håller på att utreda vidare just nu.
Är det en svensk person?
Det är ingen uppgift som jag har. Ja. Ja, men det är en mansperson. Det är min uppfattning, ja.
Kan du konkretisera från sjukvårdens sida, de 4, det var 2 stabila och 2 lite mer kritiskt. Vad betyder det?
Jag kan inte ge några närmare detaljer om skadeläget, men de 2 som är opererade, som är färdigopererade, deras läge betecknar vi som stabilt. Det betyder att det inte är akut livshotande.
Och vad är definitionen på de andra 2?
Den ena av dem som opereras som inte är stabila är alltså allvarligt skadad. Och jag kan inte säga mer än så än att den är allvarligt skadad. Och den 4:e personen har jag ingen uppgift om i nuläget.
En fråga till kommundirektören. Kommer man ha skolorna öppna nu eller stänger man några skolor resten av veckan?
det är för tidigt att säga hur vi hanterar detta. Vi vet för lite om situationen just nu och skadeutfall och så den får vi återkomma till.
Kommer det ordnas några liksom, skyddsställ på varje skola för de eleverna som går på varje skola?
Vi har öppnat 2 platser nu och sen så utgår jag från att vi behöver jobba med det här fortvarigt under en längre tid då nära och på skolorna också.
Kollar man på, liksom, på alla skolor eller specifikt kanske med gymnasiehållet eftersom det var äldre elever som går på polisverkstad?
Jag tror att en sån här händelse kan väcka mycket tankar hos barn och unga i stort. Jag tror det finns anledning att vi pratar om detta och att det kommer att komma många oroliga som befinner sig på andra skolor i andra åldrar. Så det här är någonting vi behöver jobba med brett tror jag under efterarbetet.
Vad var det för åldersspann för de som gick på den här skolan?
Jag vet för lite för att kommentera åldersspann och exakt var de som är skadade har gått. Det är 3 skolor som vi har inrymt som jag vet om. Så att jag vågar inte gå in och diskutera ålder på det här, i det här läget. Jag har inte den informationen just nu utan vi har gått upp i stabsläge. Både grundskolan och gymnasieskolan tittar på hur vi ska hantera det här framåt. Så vi får återkomma den. Och det är därför vi upprättar också informationspunkter nu så man kan ringa in och få alla de här svaren som föräldrar och anhöriga kring hur vi ska hantera verksamheten framåt. Ja, med den informationen som jag har nu så räknar jag inte med att vi ska behöva stänga ner skolorna brett. Utan jag räknar med att vi kan behöva samtala och reflektera över det som har hänt och skapa trygghet hos våra elever framöver brett. Men det är för tidigt för mig att säga hur vi hanterar skolorna framåt.
Är skolorna fortfarande inrymda?
Den informationen jag hade när jag gick hit är att så det pågående operation och då är de inrymda.
Finns det en plan för hur länge de ska vara så?
Kan inte svara på det.
Att man då inrymde de här 6 skolorna, är det liksom enligt rutiner eller fanns det en specifik utökad hotbild att man stängde de här skolorna?
Min uppfattning är att vi har fått ett larm och då rymmer vi in enligt våra rutiner. Ja. Haga kyrka och så finns det en lokal som ligger bredvid Myrorna, en lokal nära entréskolan tror jag ner mot motorvägen. Kan inte ge mer exakt information än så.
Insatsstyrkan, var någonstans fokuserar de? Är det på Ritlärska skolan eller de andra skolorna just nu? Var är fokus?
Det här är ju våra erfarenheter sedan tidigare av den här typen av händelser är ju att det är ett dynamiskt skeende så att exakt var vi är i den processen och den insatsen just nu, det vet vi inte här och nu. Däremot så vet vi att vi fick snabbt stöd av insatsstyrkan från Stockholm. Vi har också fått stöd av andra poliser som tar över grunduppdraget här i Örebro för att vi ska kunna jobba med insatsen men också proaktivt framåt, förebyggande men också tillsammans med kommunen när det gäller psykosocialt omhändertagande. Och det var, som nämndes här tidigare, det här är ju någonting som kan dyka upp. Även om man inte har varit utsatt så kan man ju ändå känna ett behov av att söka kontakt med sjukvård, med kommun eller för den delen med polisen. Och jag tänker att vi tillsammans behöver vara väldigt observanta på det framåt. Så att vi har en pågående insats och exakt var den befinner sig och i vilket skede, det kan vi inte svara på just nu.
Men vad är det konkreta skälet till att ni fokuserar på andra skolor än
här i Örebro så finns det ju, är det ju på det sättet att här har ju de allra flesta skolorna utbildats just i den här typen av scenarier. Så att en del av de här skolorna skulle jag kunna tänka mig har inrymt spontant. Det vill säga man följer de rutinerna. Men exakt vem som har gett order eller beordrat det ena eller andra, det vet inte jag och det kan vara både och. Ja, det är ju en del av den här typen av insats att man också då utvidgar och säkerställer så att det inte är andra pågående skeenden. Och det vet vi att vi då har initierat i olika delar. Men som jag sa också, skolorna har sannolikt tagit ett stort eget ansvar.
Vet vi något om eventuellt motiv till det här?
Nej, det var precis som Roberto sa att det är ju nästa steg. Vi är fortfarande i insatsen. Nästa steg är ju då att ta reda på vad det är faktiskt som har hänt och vilka motiv som finns bakom. Jag tror att den delen är viktig. Det vill säga att vi inte spekulerar i motiv utan att vi verkligen tar reda på det. Och det kommer i nästa skede när vi har ett säkert läge.
Vet du hur många skott som har avlossats?
Nej, det vet vi inte.
Vet man vilka slags vapen som har använts?
Nej, vi vet bara att det är skjutvapen, så att utredningen får sedan utvisa vad det är för typ av vapen.
Det pratas om automatvapen, men det bekräftar ni inte?
Jag kan inte bekräfta det. Jag vet bara att det har skett skottlossning inne i skolan.
Vi hade en händelse på lekskolan i Halmstad inte så länge sedan. Hur kan det här hända igen?
Det här är ju en typ av händelser som är oerhört svåra att liksom förutse. Däremot så kan man ju jobba proaktivt, man kan träna från skolornas sida på, som jag var inne på tidigare, just på inrymning och åtgärder i händelse av det här. Men vi gör ju naturligtvis allt vi kan att jobba proaktivt, förebyggande med den här typen av händelser. Vi har ju i realtid informationsdelning både här i Bergslagen och i myndigheten och har ju gör allt vi kan för att fånga den här typen av händelser. Men att helt förebygga det är oerhört svårt när det gäller den här typen av gärningar. Om man liksom speglar hur det brukar vara. Sen vet inte vi exakt vad som har hänt här och det får utredningen utvisa.
En fråga till sjukvårdsdirektören. Jag har fått uppgifter om att entrén till akuten har varit avspärrad. Hur ser det ut? Kan allmänheten komma till akuten? Eller hur ser det ut?
Jag har inga uppgifter om hur det ser ut just nu. Läget på akuten är lugnt, men vi förbereder oss på möjligheten att behöva ta emot flera svårt skadade. Så att vi avråder ju ingen från att besöka akutmottagningen som behöver det. Men det är klart att det kan bli långa väntetider när vi är i den situationen som vi är.
Har ni redan börjat transportera patienter till andra regioner för att göra det?
Nej, vi har inte behövt göra det än. Eftersom den här händelsen inträffade mitt på dagen, när vi är många, vi har en hög grad av bemanning, så har vi kunnat skapa det utrymme som behövs här själva.
Räknar ni med fler skadade än vad det
Som sagt så är det en pågående insats och det är svårt att ge svar på det. Utan vi jobbar intensivt med att säkra brottsplatsen och omgivningarna som finns där just nu. Ja.
Jag förstår inte helt det här med en eventuell annan gärningsperson. Är det någonting som tyder på att det är fler gärningspersoner?
Nej, men det råder ett något oklart läge just nu. Och det är ju ett väldigt intensivt utredningsskede som pågår. Och det är det här som gör att det är svårt att uttala sig kring det. Men det får utredningen visa framåt helt enkelt.
Kan ni säga någonting om det finns misstänkta kopplingar till gängkriminalitet eller om den här personen känner det sedan tidigare?
Nej, jag kan tyvärr inte gå in på vad vi vet och inte vet om den här personen.
Folk är ju liksom inrindade till varstans i liksom utökade områden kring Västhaga. Ja. Vilka möjligheter eller inte finns det att röra sig fritt i det stora området kring Västhaga och närliggande områden?
Nej, men om möjligt så önskar vi att allmänheten håller sig ifrån precis närheten av just brottsplatsen som är runt Risbergska. Ja. Men det är ju inte avspärrat runt hela, utan det är vissa...
Inrymd i trakterna kring Haga centrum exempelvis, är det fritt att röra sig då?
Ja, det är ju fritt att röra sig, det är det.
Kan ni säga var de här skadade personerna hittades?
Jag har tyvärr ingen sån uppgift.
När det gäller var skottlossningen skedde då? Om det var inne eller... Alltså, har det skett någonting inne i skolan eller utomhus?
Ja, men de uppgifterna jag fick initialt var att det var inne på skolan.
Och den här branden eller rökutvecklingen, vad var den?
Det har jag tyvärr inte något svar på, men jag vet inte om du kan ge något sånt besked från räddningstjänsten.
Nej, jag får faktiskt vara lika tråkig jag. Vi vet att det gick ett automatiskt brandlarm på skolan med anledning av någon form av rökutveckling där. Det var ingenting som vi larmades på initialt, utan vi larmades på det här skottlossning helt enkelt. Där vi agerar som stöd framförallt åt sjukvården i det här. Att vi befinner oss på platsen och så fort polisen bedömer olika delar av skolan eller områden säkra så bistår vi helt enkelt med att hjälpa till att få ut eventuella skadade för att de så snabbt som möjligt ska komma till vård. Mm.
Så det var inte brandlarm som gjorde att ni åkte?
Nej, det var inte brandlarmet som gjorde att vi åkte dit, utan det verkar ha uppstått i efterhand. Sen har det inte varit någon pågående omfattande brand som har föranlett att vi har tvingats till några brandsläckningsåtgärder, vad jag vet om.
Hur snabbt var polisen och hela insatsen på plats efter att ni fick larmet? Och hur bedömer ni er insats så här långt?
Nej, men jag kan inte säga exakt på minuten, men vi var väldigt snabbt på plats. Skolan ligger ju ändå förhållandevis centralt. Och det är ju en väldigt, väldigt stor resurs. Och som regionpolischefen nämnde tidigare så har vi ju även biträde från andra regioner som är här och stödjer oss i det fortsatta arbetet.
Ja, då skulle jag vilja ha en sammanfattning på engelska till BBC. Om det går.
Vi får ta via KA sen.
Får man göra det? Vi ställer det samman.
Vi kan stå här, slipper jag flytta.
Jag ska bara säga så här. Och det handlar om läget.
Ja, eller om du sitter.
Nej, jag kommer inte. Jag hoppas på. Det är nog bättre. Det gör så.
Ja, det är för dåligt.
Man klarar av varje.
Kan jag börja själv? Det blev en annan dag. Vrider upp så Dabrut får en rak.
Jag tänker att jag ska fråga. Men jag ska bara kolla om de har någon. Ja.
Kan du berätta?
Ja, du menar att vi tar in det direkt, utan vi börjar en kort bit och så går jag in senare i andra taker.
Jag är mikrofon. Ja, precis.
Ja, men jag har nog någon ganska snabbt.
Eller det.
Ja, de är expert på så här långt. En som jag säger. På polisen?
Ja, det är mycket.
Ja, jag är i pressrummet just nu, men jag ska se som verkar